they're in transit. Today we're going to focus on several topics. One, moving forward, the update factor discussion and the latest information that we have to begin to fill out our update factor matrix for 16. We've been working on uncompensated care adjustments, and we're going to spend some time looking at where we're headed with that. With the changes in the quality programs, we're going to spend a good bit of time on the aggregate amount at risk for quality programs. We've been restructuring the quality programs significantly this year, and that's still a work in process. I know that a number of you are going to attend the following meeting, which will get into more detail in terms of how we're focusing on changing the quality programs, but we're going to try to focus that at least at a higher level on where we're headed there. And then lastly, an update on where we are with the market shift process. So with that, we'll turn things over to David to get us started with the first two agenda topics.
Thanks, Donna. The first topic is just an update on the balanced update model. I think copies are provided to the panelists here. It's a little hard to read on the screen. It's essentially exactly the same sheet that you saw at last month's meeting. The only item that's changed is about maybe a quarter of the way down the page, the inflation factor. And we got updated information from Global Insights, and the inflation factor went down to 2.4%. For the coming year. So that brings down all of the other calculations slightly. So you go down to the blue near the, not at the very bottom, but just before that, the per capita growth, just using the pieces we've already filled in, the inflation, the maximum volume adjustment, and a couple other adjustments is about 2.34%. And then when you take into account a likely uncompensated care reduction and the annualization of last year's MHIP adjustment, you get down to a per capita growth of 1.57%. But there remain a number of items that need to be filled in still, so the numbers will likely go up from where they are at this point. That's really all we have on this topic today, unless anyone has comments or questions.
Yeah, just actually one item, and it's actually up at the top in terms of the maximum allowed revenue growth. And this is following from the comments that we made last month about addressing any underage for the first year. It's my understanding that, in fact, the maximum revenue growth for the second year would be the cumulative growth for the first 2 years divided by what the actual update was in the first year. So if we're just talking, that's not necessarily what the Commission may do, but in terms of the maximum allowed revenue growth under this model, it should be consistent with what's in the agreement, which is 2 years of cumulative growth at 358 plus 2 years of population growth. So I think from that standpoint, the top line should at least reflect what the cumulative 2-year growth is, and we can, if we wanted to, pull out whatever we think the estimate is for the first year's growth.
So you're suggesting that we should have two sides to this, one of looking at the current year and one looking at cumulative?
Well, I'm saying I think you have to look in the cumulative if we're going to address how we deal with any underages from the first year. I think you have to at least show the total revenue growth, and I think the other point is just a fairly straightforward one. This is not the maximum growth for the 1 year. When we're in the second year of the model, it is the cumulative growth of 2 years of 358, 2 years of population growth, less, or technically, I guess, divided by whatever the increase is in the first year. So if you're just going to put this as 1 year, I think it has to be the much higher number because we have achieved those savings in the first year.
And so the bottom would also reflect 2 years?
No. The bottom is just what the commissioners out of that total revenue amount has decided to give out. It could be very much the same as if you looked at it 1 year, the inflation, all right, plus the population growth. You may decide to do that the same way as you did the first year, but I'm suggesting that the total amount that is available for the commission to distribute in the second year is the cap for the 1 year plus or minus if this savings, any increase from the first year, and then we would carry that forward into the third, fourth, and fifth year of this agreement as well. But the components down below, I wouldn't be changing at all. That would be the actual amounts that the commission, that all parties, I think, hopefully are agreeing to allocate out of the total amount available.
Well, let us fool around with it a little bit. I think there's an opportunity to show the latest projections of what is going to happen for the current year along with next year and show a combined multi-year impact of that.
Other comments, questions?
Donna, if you decided to do something like that, I mean, I would suggest keeping the annual and then putting a cumulative column so that you can see. I think we even did something, well, I forget what it was. Didn't we have like a tools column last year? I don't understand. Can't remember exactly what it was for, but to clearly, you know, so we can identify the annual amount and don't get, you know, don't merge them together. So I think it would be, from a presentation standpoint, it'd be easier to see a cumulative separate 2 columns.
Let's work on getting it presented.
Next topic is uncompensated care, which is a significant component of filling in the rest of the balanced update. So over the last couple of months, the Commission staff have really been focused in trying to understand the impact of the Affordable Care Act on what's going on with uncompensated care. So we started out trying to compare calendar 2013 experience in terms of self-pay and charity as the expected payer in our case mix data to calendar year 2014 experience, since the ACA Medicaid expansion was January 1 of 2014. We shared some data with the hospitals at the end of December showing them trends in the self-pay charity expected payer from 2013 to 2014. And one of the areas of feedback we got is a number of hospitals used to report Medicaid pending cases as self-pay charity, including in much of 2013, if not all of 2013. And then they've kind of switched to reporting it as Medicaid, which is what the Commission has directed all hospitals to do. So there were some that were always reporting Medicaid pending as Medicaid, some that were reporting Medicaid pending as self-pay charity until July of 2014, and others that switched from self-pay charity to Medicaid in July of 2013. So there's no consistency across the industry, which made looking at the data that we had shared very difficult because each hospital had a different story and had to understand that. So to try to address this issue and sort of compare apples to apples, we worked with Medicaid and with CRISP to match our case mix data against the Medicaid eligibility files. And what we were doing is trying to identify when someone was actually enrolled in Medicaid, did they have a hospital charge in that period of time, and truly identify the charges that were associated with a Medicaid coverage period, however it was reported in our data. And if you look at the next slide, just to give you a sense of what came out of that, so we're showing 2013 and 2014. This is January to June, so the first 6 months of each calendar year. So we're showing down the left-hand side who the primary expected payer was in our data. And again, these were people who all ended up actually being enrolled and covered when they had the service, covered by Medicaid. You can see the largest payer in both years was Medicaid, with more than half of the total charges were identified as Medicaid expected payer. And then Medicare is the other large one, with about a third of the charges. And again, that makes sense because we're going to be capturing dual eligibles in the Medicaid eligibility files. So these people likely were eligible for both, and Medicare was probably appropriately identified as the primary payer, with Medicaid as the secondary payer. And then you can see self-pay charity. There was about 4% of the charges in Medicaid in 2013 where had been identified in our data as self-pay charity, which is somewhat consistent with the idea that some of the Medicaid pending was being reported as self-pay charity. And that number has gone down quite a bit in 2014, which again makes sense as hospitals started switching to reporting Medicaid pending as Medicaid, and with the expansion, I think more people were actually ending up qualifying for Medicaid. And then we see the commercial at about 7%. Our thought is that this is some people who they had at least some access to commercial insurance, and the commercial may have been the primary payer, again, with Medicaid being the secondary payer, and the percentage is flat over the 2 years. The next slide shows you kind of what we did with the analysis. If you look at the chart down at the bottom, we took what was identified in our data as self-pay charity. And again, this is at January through June of 2013 and 2014. So that's what was in our data, 357 million of charges in 2013, 183 million in 2014. And then we made two adjustments based on the CRISP analysis. First, we removed charges that were associated with the Medicaid coverage period. So if somebody was reported by the hospital as self-pay charity, but they were covered by Medicaid in that period, we assumed that was a Medicaid, and ultimately was paid by Medicaid, and we removed it from our count of self-pay and charity. And then we added charges that were recorded as Medicaid, but not associated with a Medicaid coverage period. We added those to the self-pay charity. So we said the hospital said they were Medicaid, but Medicaid says they weren't covered in that period. So our assumption is that those likely ended up being self-pay and charity. So we sort of end up reconstituting the self-pay charity data, making those two adjustments, and we show for 2013 446 million of charges in that 6-month period and 296 million of charges in 2014. So we end up with about 150 million decrease in self-pay and charity over the first 6 months of the 2 years. Any questions about that?
David, this is Ray Gray. Medicaid goes through a disenrollment also in the fall. I'm just wondering, curious, what period the CRISP data covers. I know a lot of people were disenrolled from the Medicaid program and they had to reapply. I think that's an annual event. This year it seemed to be significantly greater because of the large expansion program and concerns about people coming into the program maybe inappropriately, for lack of a better term.
One thing, and I'm going to turn it over to you. Just to be clear, the data is for the first 6 months of the 2 years, so it would be before the disenrollment issue. I'll let Tricia talk about that.
So we did delay renewals, eligibility renewals. That was the reason why in the last year there was this big batch renewal period. But the majority of them came back on. So it's very typical in terms of Medicaid eligibility. A lot of people don't fill out their application right away, but they do come back onto the program, the majority of them, and they get retroactive coverage. So, I don't think there was a huge fall off. We will be experiencing a different type of re-enrollment next year into the new eligibility system, and that experience could be very different. But in terms of last year, the majority of the people that fell off came back onto the program, and we're still experiencing an increase in enrollment.
David, this is Stu Gutterman. I have two questions just in terms of understanding these numbers better. How do the numbers at the bottom of this slide relate to the numbers in the previous slide?
So First, what Chris did was go through and identify who was actually covered by Medicaid and which hospital charges are related to that. And then so we knew from our case mix data which charges really were related to Medicaid. And knowing that, we took our case mix data for the self-pay and charity, and we said, well, for those folks who were actually enrolled in Medicaid, but the hospital thought the expected payer was self-pay charity, we're going to consider those to be Medicaid. You know, that we're going to remove them.
So basically, the top line there corresponds to the 4% and 1%.
Right. Well, it corresponds to this is the total self-pay charity identified in our data. The 4%, 1% really corresponds more of the 75 million and the 27 million.
Oh, okay. And from what I get from this, so hospitals, there were a lot of patients that hospitals apparently thought were Medicaid who weren't, right? And so they didn't get paid by Medicaid.
Right. They thought they were Medicaid. They reported them most likely as Medicaid pending, thinking they might be Medicaid eligible. And then when the person went through the Medicaid eligibility process, they were not deemed eligible.
And vice versa. So they recorded them as self-pay, but then they ended up being Medicaid.
But there were a lot more of the form of who they thought were Medicaid who weren't, than because the 165 and the 140 are a lot higher than the typical.
Right.
Okay. Thanks.
Other questions on that? Okay, so the next slide, we took that 150 million reduction for the 6-month period, and we just doubled it to try to annualize the numbers. So we came up with 299 million overall self-pay charity decline. It would be the expectation for the year. The UCC policy adjustment that was made prospectively for fiscal 2015 assumed about 166 million reduction in uncompensated care. And that was built off the idea that the Medicaid, what was called the PAC population, who had been people who had a very limited Medicaid benefit package in 2013. In 2014, they had full Medicaid coverage. All of their hospital visits were being covered by Medicaid. It was expected that that full coverage would reduce uncompensated care by 166 million. Obviously, overall, the Affordable Care Act Medicaid expansion has resulted in a much bigger decline. So we see the differential there about 133 million. And we would be looking at that as sort of a rough sense of what kind of additional adjustment we would want to make to uncompensated care for fiscal 2016.
Sorry for traffic and rain to be a little late, but I just was wondering, what did you use from Chris to be the data point to pick the Medicaid? Was it hospitals' records or was it Medicaid's records of payment?
We had Medicaid eligibility periods for everyone enrolled in Medicaid in 2013 and 2014. So they matched that using their master patient index against our case mix file. So all the hospital
So
charges.
it's Medicaid data, basically.
It's Medicaid's enrollment data and the hospital data we receive.
Thank you for the question.
So it's not Medicaid payment data, it's Medicaid enrollment data. Medicaid payment data would be difficult because it's really the MCOs paying a lot of the claims, and that would be a whole another long-term exercise.
Yeah, just one question on this, and it may be a very minor adjustment. Does price increases or any kind of price leveling factor into this calculation, or should it? Or is that just a really minor point we don't need to worry about? I mean, over this period of time from 13 to 14, we had rate increase, so you'd expect a higher level in the next year just simply because of the rate increase. So do we need to adjust that at all here, or is that just a really minor point?
It's probably pretty minor on the self-pay. If you look at the dollar amount, you know, and you're thinking, you know, one and change increase over the period, it's not very much money on $400 million.
Okay. I don't know if it was worth looking at. Thanks.
Do you have questions? The next slide just shows some of the information from the unaudited fiscal 15 financial data that we receive from hospitals on a monthly basis. So the left-hand side shows you the UCC policy adjustment in fiscal 15. We see UCC at 6.14%. Unaudited data through November, so 5 months of the fiscal year, shows about a 5.4% uncompensated care rate. So this seems relatively consistent with the data we just showed you. It's just sort of a second data point that shows a significant decline beyond what was sort of built into the fiscal 15 rate. The sort of second issue that we work with CRISP to examine is how has the utilization changed for the people who enrolled in the expansion? What was their hospital utilization prior to the Affordable Care Act getting them coverage in Medicaid, and what is it today? So what CRISP did is they took anybody who was enrolled in the expansion in the first quarter of 2014. So whether you were enrolled for the whole 3 months or for a day, they took all those people and they looked at what their 2013, calendar 2013 hospital charges were. And we're showing the first 3 quarters of 2013 here. And they identified almost $400 million of charges for those people in the first 3 quarters of calendar 2013. And then for calendar 2014, we looked at the first 3 quarters of data for the Affordable Care Act group. And this includes everybody, not just people who were enrolled in the first quarter, but anyone who enrolled in the expansion at any point in the first 3 quarters. You see about $587 million of charges. So almost a $200 million increase in total charges. But again, it's not quite a perfect comparison. There's more people in the 2014 data. And we're working with CRISP to do a better apples-to-apples comparison so we can see exactly what that growth is. But there does appear to be overall growth in hospital utilization by this population. The next slide shows the growth is sort of uneven between the PAC folks who are in the expansion and the non-PAC folks who came in. We see roughly a 30% increase in utilization for the PAC folks, at least in charges, not utilization, and an 81% increase in charges for the non-PAC. One of the things we're working with CRISP on is just to make sure whether they're having more difficulty matching people in the non-PAC. I mean, for the PAC folks, they were enrolled in Medicaid in a limited basis in both years, so they may be having a higher success rate. So we're just looking into that. We're not sure if there's any concern there or not, but we want to understand that.
When you get that straightened out, you'll be able to tell whether or not it was the PAC primary care management that showed lower utilization when they got the Medicaid expansion.
It'll help. It'll help because I don't know that we're going to be able to definitively say that. But I mean, that is one of our assumptions is these people were getting primary care and they had at least ER coverage and they were engaged with an MCO, so there was likely a little bit more care management going on for them than the non-PAC.
And the PAC population is a fairly high need patient population historically, so it that they were using hospital services even if they weren't covered, and I think that initially at least it looks like that's the case. We would expect it to settle down even more, with the MCOs managing the care. Even with the non-PAC, we would expect to have some initial pent-up demand being served, and we can see that in the DRG data. Orthopedic surgery is one of the big pop-up areas of utilization, but that'll settle back down, as people have their pent-up demand met.
I don't want to overcomplicate this, but on the non-PAC population, are we to assume that most, if not all, of these people that were in calendar 13 were the self-pay charity? I mean, one of the questions I have is whether what we see in the calendar 14 utilization is a whole bunch of folks from commercial plans, crowd out issue, commercial plans moving to Medicaid. because they hit the eligibility requirements under the expansion, but in fact they didn't come from, if you will, self-pay and charity, but in fact came from a commercial plan. And that may be one of the reasons why you see that increase.
We're measuring if they use commercial in the base period. So we're measuring if they use any care at all in the hospital. So that's what we're trying to do, a pure analysis of looking at a per person use, not Medicaid coverage, but just a per person use. So what services did that person use, even if it was covered by commercial insurance in the base year versus the current year? So if they were covered by commercial and they used the hospital, then that's in the use in 13, and it's in the use in 14. So we're trying to look at how did this drive use rates in the hospital, and we're less confident with the non-tax. You know, we just want to kick the tires on the CRIS data, the matching process, to make sure there's not just a lot of that there aren't some matching issues there. But it actually makes some sense in terms of expectations. But both of these groups were uninsured in 13. The PAC, because we only had ER coverage, right, and the non-PAC. So both of these groups would be partially in self-pay. The non-PAC group, some of that group could have had commercial insurance. Let's say some of that group did have commercial insurance, not just could, but did.
In which year? In the base
13.
year? In 13. Because I may be
Let me clarify for you. So the calendar 13, that non-PAC number includes whoever the payer was, just total utilization for the first 3 quarters of calendar year 13. So it would include if they had commercial, that's captured in there, or if it was self-pay, that's captured in there. For 2014, right now what we're showing you is just the non-PAC that was while they were enrolled in Medicaid, and we're working with Chris to do the other nuance of what's the total utilization for those people, whether they were in Medicaid or not. But it's purely the while they were covered by Medicaid in the 2014 numbers.
Do you have the breakdown of how many you are unable to match? So out of the 270,000 new folks, how much do you not have experience for in 2013?
Right, we've asked for that. I haven't seen the numbers yet.
So, Mike, is that confusing? Should we just stop and go over it once again and explain the analysis one time again? Because it is, we might be kind of, are we going too high level?
Well,
we need to describe a little bit
I'll
more.
tell you now why I'm even more confused, because if the 100, you said 147 is whatever their pay class was, well, there's $15 billion of hospital charges, whatever their pay class was. So what does this $147 million represent?
These are, so what they did is take anyone who enrolled in the expansion in the first quarter of 2014.
Right.
So I mean, I want to say 200,000 people. That may be a little low, but 200,000 people were enrolled in roughly in that first quarter. They said, what was their utilization of hospital in 2013? Whoever their payer, we just wanted to understand what's the utilization by that group of people. And that group of, the non-PAC was about 100,000. The PAC was about 100,000 people. So the non-PAC, those 100,000 people who enrolled in the first quarter of 2014 in the expansion, used 147 million of hospital services in the first 3 quarters of calendar year 13.
Okay.
All payers.
Thank you.
So David, in the 2014, that 267 million represents people that not necessarily are included in the 13 number. You're using eligibility files.
Yeah, it's any charges that were incurred by anybody enrolled in the expansion at any point in the first 3 quarters of 2014. So it's not just that first quarter, not just the first quarter enrollees. That's the bulk of them. Is most people, all the PAC people, just switched over, and working on getting a more peer comparison of the same people.
So this is a progress report, not the end, but basically it's showing that PAC went up a little bit. I mean, 30% is more than a little bit, but PAC went up a little bit, and non-PAC went up a lot, relatively speaking.
Donna,
yes.
Would there be any value in comparing utilization rates of the new enrollees to the utilization rates of previous traditional enrollees? I mean, we look at that all the time at Maryland Physicians Care. We can definitely see a higher utilization rate when people first come into Medicaid. So I think the assumption you're using is a good one, that they do use more services. What we've traditionally done is sort of segregated the populations and keep the disabled out unless they are disabled, and just look at the new enrollees versus the old utilization patterns. It might be another way to get at that.
Yeah, I think our expectation based on the literature and other knowledge information is that we would expect that to settle back down after the enrollment period. So, no, I think, is that consistent with your experience, Ray?
Yes.
So you
yes, there is a phenomena when people first become eligible and covered, they tend to use higher, and you have, I mean, we look across the board, we don't look at just hospitals, but higher ED use, higher primary care physician, higher services, and then that sort of settles back in after that period of higher use settles back down.
Do you have an estimate of the period of higher use?
It's usually 3 to 6 months is what you see.
I think Ray's point, and I'm sorry for my being tardy, but I think Ray's point just now is what my question was. It was that I know there was this expectation about also, reduction in uncompensated care, which may not have been quite what was anticipated on the hospital side to this point. But one thing which I think could be telling is to break it down. You have the utilization numbers, but if we knew what was emergency department utilization, as compared to other service, that might be also a good indicator to know. And my question, of course, which is not to spend a lot of time on, and I know you don't know the data, but to get the full picture, it's also would be really interesting at some point with the healthcare commission to know utilization in the outpatient sector. So that's kind of my reaction.
Yeah, the next slide, we've covered some of these topics, just sort of addressing that we think a significant portion of the Medicaid growth is sort of a pent-up demand and people coming in and utilizing services who didn't have access. We've been trying to look at product line, and it looks like there's some evidence that like orthopedic usage is up, which would make sense if people didn't have insurance and now they're getting procedures done that they couldn't get done previously. So our thought is that a good portion of this uptick is sort of a one-time that will settle down, but that there does appear to potentially be some overall uptick that may need to be adjusted for in the 2016 rate. One other thing, this next chart sort of tries to look at, imperfect, but it tries to look at the growth in hospital charges by the expansion population by quarter. So it's comparing 2013 to 2014. And you can see the growth has slowed by quarter. So we saw substantial growth in quarter one, and it's still substantial growth each quarter, but it's slowed down a little bit. So it seems to support the idea that there is some pent-up demand. People first come in and really use a lot of services, and it may be slowing a little bit as time goes on. Right. Quarter one versus quarter one of the prior year. I have the data. I don't recall off the top of my head what that was. We can certainly provide that next week. Other comments, questions on this? All right, finally, just as the next step, as you heard, there's a few things that we're working with Chris to improve the overall data quality or to just get a little bit more information. So we're continuing to work with them, and we would expect to have any new information for the next work group meeting the first week of March. We're going to be sharing the uncompensated care data that I walked through at the statewide level. We're going to be sharing that at the hospital level with the individual hospitals, to give them a chance to look at the data, see if it makes sense to them. We're also working on reviewing the write-off and recovery data. It's something we've collected for the first time from hospitals in the last year. We've received from most hospitals about 9 months of data. We're in the process of analyzing that, and we expect to report whatever information we have at the next meeting to give you a sense of the trends there by payer. And we're going to continue to analyze the Medicaid trends to, again, try to better understand how much of that growth is pent-up demand versus sort of a ongoing increase in utilization that needs to be accounted for in the 2016 update.
And you'll be able to do by procedure or product line too, ongoing, to be able to see. My question centers, it looks like we're seeing an uptick in procedures that are not necessarily emergent but affect quality of life. We haven't seen an uptick in, say, the cardiovascular procedures, which I would class more along the emergency or more urgent, actual life-extending procedures. So to me, that would be interesting, and also what Barbara said, to get into the outpatient to see exactly what is increasing, and whether it's urgent or quality of life, which is equally important, but it says some things about our healthcare system, what we've been taking care of adequately, how we've been taking care of the emergent, very urgent things, even without an expansion of the Affordable Care Act and Medicaid expansion. And now we're being able to get into more of the quality of life issues for patients with the Medicaid expansion and the Affordable Care Act expansion.
We're definitely trying to look at the product line information. And once it gets beyond hospital, we don't have the data right now to talk about non-hospital outpatient services at this point.
We do have all of our, because of what we're doing with market share and trend analysis, we do have all the claims tagged to a product line. So it isn't a big effort once we get done with the analysis to match the data to a product line and look at it by product line. But I do think it it definitely does show some uptick in utilization of things that people might not have had access to before, like orthopedic care. Emergency room is up also, and I think once we get around to pulling in months like December, we'll have a hard time figuring out whether it was the flu or something else. And we don't have the outpatient data outside of the hospital. We have hospital outpatient data, but we don't have office data.
And to see if you have an uptick in orthopedics from Sunday a week ago from the ice and the 40-car pile of over 40 and things like that.
Yeah. So it's but so we'll have a little bit of trouble with the flu season differences between years, but we can look at those more at a macro level, maybe. So, I actually did have a chance to talk to some doctors about it because it's always good to ask the clinician. And I was talking to the doctors in Montgomery County, a relatively wealthy county, and they see some orthopedic surgeons, and they did say that they were seeing more Medicaid patients, and that they actually, until the recent reduction, felt that they were getting paid the same amount as they were getting from Medicare, and that they were expanding access to the Medicaid patients who had gotten coverage. The payment rates are down some, but it's not through the floor with the cuts, but they did actually tell me that they had expanded coverage. They were telling me that they felt that the patients were a little bit higher risk than some of the traditional patients that they saw, and that was the one difference, that they actually had to spend more time with some of the patients. But it was a good conversation and very interesting that there was a definite being granted.
That's all we have in uncompensated care, unless there's other questions.
And next is Shule. Good morning, everyone. So we are going to switch to the, I guess, third topic, aggregate amount at risk in quality programs. You have the printouts in front of you. I'm going to walk through them, but in general, just as a summary and kind of where we are, as you know, most of the performance period started in January of 2015, and ideally we would like to have all the determinations done before the performance period starts. Given we have some data issues with CMS readmission rates, we had postponed the final recommendation in January to February, and we will be postponing it again to March because we haven't gotten a good data, reliable data from CMS yet for the readmission. However, we think that that's kind of, we could isolate that a little bit and work on the details of the scaling methodologies and some of the other things. So by the time we get the data, hopefully we'll be ready for the final recommendations. We are planning to have an update for the Commission next week and get their feedback on some of the decision points that we'll be discussing today with you and also with the performance work group. So I'm going to start, I'm going to try to give you as high level as possible, but I'll encourage you to ask me questions so I know how far deep you want to go into the scaling. So first we are going to start with the readmission program. Yeah. No, go ahead. Mm-hmm. So the question is, what is the nature of the data problem with Medicare? Medicare has been giving us monthly readmission summaries, national versus Maryland, and they've been revising the way we are measuring readmissions. We've got 3 different estimates, but each estimate seems to be different. So what is happening is, as they revise the readmission, basically what they are doing is, initially they just ran the claims, looked at the total discharges and the readmission rate. And then now they're saying, oh, well, but you have to be enrolled in the Medicare for a 30-day period for us to see your readmission rate. So our denominator is cleaned up. As it's cleaned up, our readmission rate is going down. So it's getting Maryland's readmission rate closer to the national estimate at one level.
Not close, but close.
Closer, right. Right, and then the second one, as they make the change, the trends are very volatile. In some data I saw we were declining faster than the national. In another one I saw we were declining slower than the national. So in addition to the rate, the trend seems like up in the air, and at the end we don't know the overall impact of these revisions on our readmission rate and the target. They are doing several changes, so that's one. The other one, they are going to be looking at the swing beds, the issue about national numbers excluding the psych and rehab beds in acute hospitals versus in ours, they are included. And then they'll be also looking at the planned readmissions. As you know, in our readmission program, we exclude planned readmissions from our calculation, and they agreed to do the similar exclusion, so we are more close to what our internal data is. We received access to their confidential claims in January, so we haven't gotten the actual data, but now at least we should be able to look at the claims data and do our own analysis as well this month. All right, any other questions on the readmission? So what you have is, we've been discussing, but looking at the trends, if you remember last year we targeted 6.7% reduction in readmission rate, and our trend is lower than that. So we are concerned with our progress on the readmission rate, and we've been discussing to have both the positive and a negative incentive on readmission. Current program on readmission is 0.5% additional revenue if a hospital reaches or exceeds the target of 6.7% reduction.
Just for those folks who may not have been here, the derivation of the 6.76% target that was set, my recollection was that we had two components. One was we knew we had to reduce our rate of readmissions by whatever, 1/5 of whatever the beginning years, the calendar 13, the base year difference was. And then we just made an assumption about how much we thought the national rate of readmissions would decline. My recollection is we thought that would be about 5%. And the other piece, the first piece, was 1.76%. Are we still waiting for data on where the national numbers is to get that cleaned up? Because my sense is the national decline has been nowhere near that 5%.
That's correct. So here I modeled, just for illustrative purposes, 10% cumulative. So we are working on the base year as well as the current projected year. And the trends, unfortunately, because of the data changes, we no longer have access to the old data. So it's hard to see what the trend is based on the old methodology. So we are trying to find a way to really look at the trend with the new data and the new estimates, in a sense.
And also, we had the implementation of the 2 midnight rule issue during this time frame, which just kind of rattles a lot of the location. So we're not sure how that's affecting the data either, and whether that's a temporary impact or, you know, is the rate really declining? Is the readmission reduction rate declining, or is that a temporary impact, or is it a little bit of both? So it'll be hard to unravel that. But clearly, the readmission reduction rate that's showing in the data is lower.
So in terms of modeling for the scaling, we did 3 options here. You could consider them as 2 options as well. So in the model, we are assuming a cumulative reduction target of 10%. And the reason why we are doing cumulative is because if a hospital is doing improved much more than the target rate, if you don't do cumulative, they're going to be losing that, and we're going to rebase it. So I think everyone kind of agreed that we would just keep the calendar year 13 as a base and then add cumulative targets. So we would credit hospitals who have faster gains than the rest of the hospitals. So if we were to put 10% reduction rate cumulatively for calendar year 15, I also calculated in kind of getting a sense of what the rewards or penalties are. The savings, here it says required reduction as a percent of inpatient revenue, 1.2%. So if the hospital reduced their readmission rate by 10%, the revenue without any expenses here, just the revenue gain would be 1.2% of their inpatient revenue. And that's based on the average readmission rate of 12.45%. That's on the inpatient, right.
Again, and that's all payer accounts.
Right. We could calculate the Medicare one. In general, Medicare readmission rates are around 18%, so you have a higher Medicare readmission rate, but then you have a lower revenue base. So on the payment scaling options, the first one is the single scale. So in this instance, the option is, so we have the 10% target. If a hospital reaches 10% or higher, they would be receiving 1% of their inpatient revenue as a positive incentive. So currently, this was 0.5%. So we are doubling the positive incentive on the single scale. And then, well, this has to be negative. So I'm sorry, there is a mistake on the 5. So after that, they all are negative. So this is not correct. So if they don't reach the 10% target, what the proposal is to have a negative scaling for all the hospitals below the 10% target. So So I will send you a corrected single scale for you. But just assume that all of below the 10% are going to be a negative adjustment. And we are capping the maximum penalty at 2% for a hospital which has 8% increase or higher readmission rate. Right. So it's the question is the 10% or less is the readmission rate reduction. So if you reduce your readmission rate 10% or more, the positive incentive, you're going to get additional 1% revenue based on an inpatient, 1% inpatient revenue. Below that, any hospital who doesn't either achieve the target, so you may still reduce your readmission, but you didn't achieve the target, or you have an increase in your readmission rate, there is going to be a revenue reduction in the program.
So when you're looking at the revenue gain, should we, from economic purpose, should we look at that at 50% of variable cost? I mean, assuming 50% of variable, whatever the variable cost factor is, but assuming that there's a variable cost factor at the current rate, look at it in that way for economic terms. We don't gain up to 1.2%. You're going to have some cost associated with that reduction factor.
Here, our estimate was kind of to the budget impact. You know, if yeah. Right. So.
No, and that's what I'm trying to do too. Yeah. So the way I look at this is, if we reduced readmissions by 10%, I'd have to charge everybody else 1.24% more. But that wouldn't be my economic gain at the hospital. The economic gain would be maybe 0.6% or argue whatever it is, some fraction of that.
Right. So the idea here is with the 1% additional revenue, we were trying to increase that gain from the readmission reduction. Right. So then if you reduce this on a half, then it's going to be 0.6%. You're saying your gain is. And here the maximum reward that we are trying to get is 1%. So it's the double of what you would be saving. Yeah.
I think some people might look at that and say, well, the hospital's profit was up 1.2%.
That's right.
Right. They'd have the variable cost, and then they would have the cost of the intervention. So, you know, that's actually, you know, one of the issues is to make sure that there's adequate emphasis.
I do have a question on that scaling. What is what I think I heard you say is that the only hospital that would get rewarded is one who reduced 10% or greater.
Right.
What's the reasoning for that if you're looking at a single continuous scale? Why wouldn't, in other words, why wouldn't say anyone between 4% total reduction and 10% get some scaled reward, and then anyone who had only a slight reduction or an increase in readmissions?
Yeah, because the 10%, if you remember, is coming from the statewide target. So we need to make sure we reach that statewide target. So if we don't link the rewards to that target, all our hospitals could be under 10% and receive some revenue, and we will still miss the state target. So that's why the rewards are really for the better performers who are achieving that 10% target.
Maybe what he's saying is you should go up on the scale. So if somebody went to an 11% reduction, they should get a bigger hit than somebody that had a 10% reduction.
Yeah.
Where I think you do it from the top down, and maybe you need to extend it up. And I think that's what you're saying.
That's part of what. Yes, that is part of what I'm saying.
I agree with that. I mean, you know, if you go higher than the 10, but I think you were saying, should you get a reward if you don't hit the 10? And I think Shirley is right. We shouldn't, because we haven't hit the target. But if you do go above the 10%, and you do, then maybe there's an opportunity for.
The reason I'm also raising that again is because then it becomes very critical as to what that whether the 10% should be 9% or 11%, right? And as I said, based on this first year, we only rewarded a handful of hospitals because we thought the national rate would decline by 5%, and so only those who got 6.76% or more are getting rewards in next year's update.
Mm-hmm.
What I'm suggesting is if we had a good crystal ball, a better crystal ball, we might have said 5% here, not 6.76, and have more hospitals receiving rewards for all the efforts they had in improving their performance.
And I think the 10% is in recognition of if we would have kept with the 6.76, the cumulative would be 13.5. It's recognition that you're right. We haven't nationally. They haven't.
But it's still a debatable point. I mean, I would say if the nation is only going down 0.5% or 1% a year, then the 10% is way too high a number.
I wouldn't focus on the 10%. As I said, it's illustrative purposes. I really have no idea what the number is.
But that's why I think then the scale becomes important.
But then the other issue is, since we are doing cumulatively, if a hospital is improved by 15%, they are more likely going to get the additional reward for the 15, for the 17, like next year. So I mean, sure, you can do a cumulative and you can extend 1%, but then are you going to give 0% or somewhere close to the 10%? So where is that threshold that you want to get it?
So I think Mike's, if you're saying maybe we got it into the end zone, so we got that. That's the 1%. Maybe we need a field goal range.
Again,
football analogies. Football season's over. No, again,
if you get it to the 30-yard line, you should get a chance for the 3 points.
Again, I
think
what I'm looking at is the number of hospitals that are being rewarded may be very disproportionately. There may be a disproportionate recognition of those who are investing all of these resources and making progress, and may, first of all, exceed greater than 10%, but also exceed greater than a number until we know what we set as a target. To me, it seems it's hard to identify what that scale should look like, I guess is what I'm saying.
I mean, the target, it could be a 5, it could be a 15, right? Right now, we don't know what that target is. The concept is, let's assume we determine a target statewide based on the Medicare data. And the reward should go to hospitals only go to achieve that target or do a better job than the target.
Okay, and can I just ask one last thing, and this is just so I think for the average reader of this, we get into these discussions of percentage point versus percentage. I want to make sure I'm understanding that if your rate of readmissions, let's say, in the base year was 10%, the 10% decline that you're talking about is bringing that rate from 10% down to 9, not to 0. It's 10 to 9.
Mm-hmm.
It's that different. That's how the 10% gets calculated.
Right.
All right. I just want to make sure everyone understood that in this calculation.
So I think I hear 2 questions being raised. So I just want to check and make sure I'm understanding. One is what the target should be, right? And the other is, should the scale extend beyond whatever that target is,
mm-hmm.
right? And then I have a question. Okay, so I'm straight on that. I have a question. Then so this column 1, the single scale column, it's not just that minus signs are missing, right? The numbers are going to change.
Right. Numbers are going to be much smaller at the beginning and then increase. Okay. I would ignore the whole thing. Sorry.
Okay.
Julie, I have another question that kind of runs through all the scaling, and I just started to take a look at similar on your next schedule that you provided us on and see
mm-hmm.
how did it affect different hospitals. And I took 2 hospitals that have the same gross revenue, but different starting points in their readmission rate. So when we're doing it on a percentage of where you started, it seems like you're disadvantaging the hospitals that had higher readmission rates over those that didn't. I was wondering if anything was done with that. You can take a look at the dollar values against the gross revenue, and it's a pretty substantial difference.
Mm-hmm.
So I wondered if there was a way to adjust the starting points so that everybody was on an even playing field, because we're not right now with this just year-over-year comparison. And that seems to me sort of a basic inequity to the scaling process that should be considered.
So doing a % improvement is adjusting it a little bit that different. So as Mike pointed out, the required adjustment in terms of numbers, 10 versus 20% readmission rate, is a different number for them. At this stage, we have no solid way of judging if a 10% is a low readmission rate compared to a 20%. As you know, there is a lot of national progress going on the socioeconomic determinants of readmission rate. So we need to take into account. In addition, the data that we have with the out-of-state issue, some of the neighboring hospitals look like they have a lower readmission rate, but we know because we are missing the data, it's not that they have a lower readmission rate. So with that, we are still keeping this as an improvement, and with the %, we are hoping, that it will equalize the playing field a little bit. However, we are also looking at some maybe exception rules. If a hospital is improving their readmission rate, but if we determine a way of saying, okay, we are kind of a little bit confident that they have a low readmission rate, we may exempt them from the penalty. But we are still working through the details of how you can go about and judge if they have a low readmission rate. And lastly, our statewide readmission rate. Iterations I told you, and I don't feel comfortable putting in front of you, but at the same time, all the data we looked, our statewide readmission rate is high. So at that point, even if our lower hospital may have a high readmission rate in the national scene.
So I'll take this comparison I was talking about offline and show it to you afterwards, but just as an example, 2 hospitals, same revenue base, same expected readmission rate. One is getting a 0.4% of their total revenue reduced, and one's getting a 0.6. So I'll show it to you afterwards, but that's to speak to it's a difference in starting point, and that seems, if you're like type and your socioeconomics are similar, that seems inherently potentially an issue with the scaling approach.
But I think the precision of like type similar isn't that precise, and what is known is that on every single measure that we look at, we're high. And so if you pick better performing benchmarks for any hospital in the state, you're going to find better performing benchmarks that are lower. So in order to meet the test, we need to have people focused on it and investing in it. And the policy would be a reflection of that.
I'm just saying I think it's disproportionate.
So that would be saying if you're a B student, it's harder to get to an A than if you're a C student to get to a B. And I don't know that we're convinced with that based on the data that we've been looking at. That's not necessarily a convincing argument from the data, that it's harder to get to an A than to get to a B.
This is David Johnson. I just want to, and I think Shulei's brain probably processes these things better than mine, at least. And maybe, so what I'm saying may be too oversimplified, but what I'm thinking is, let's just say, to keep it simple, if there were only 3 hospitals in the state, if we hit the target and Hospital A did well in reducing readmissions and Hospitals B and C did poorly, among the 3, if we hit the target, shouldn't the incentive program be designed so 100% of the reward goes to Hospital A, and Hospital B and C lose in proportion to the amount that they contributed to the state trying to hit the target? So in other words, you develop a pot of money that says this is the incentive that will be split among all the hospitals, or disincentive. And the portion that goes to each hospital is directly tied to their real dollar contribution to, or not dollar, it's number of readmissions. You know what I'm saying? And I think that way those who do really well could get potentially a really large reward, higher than where we cap it right now. Because capping the max reward also concerns me. And I'm thinking, if you did it more the way I'm suggesting, wouldn't that be a way of letting all the reward go to the hospitals that have done well, and those who do poorly get the appropriate penalty based on how poorly they did? And I'm saying that's very simplified. I know you can process those things better than me, at least probably the most of us, but is that potentially an approach?
I think that almost sounds like a revenue neutral pool, and we are stepping away from that because it has issues in terms of predictability. So if everybody did really well and nobody did poorly in a revenue neutral pool, you would reward nobody. So we want to make sure that we have the maximum approach to get everybody focused on doing, improving. And so if you think of it more like the Medicare STARS program, where if you get the 5 stars, you get more money. So this is more like a STARS program, where if we can get everybody performing well, then they should all be able to get more money. So we have to figure out how much money to put into the positive or the negative. But if we think of it more of like a STARS program.
And I agree with what you're saying. I think it should not be revenue neutral. I'm not quite sure how to make the math work, but my sense is that it probably could work. You could just change it from being revenue neutral to tying the aggregate reward or disincentive to what has been accomplished. But my bigger issue in all that is the issue that's already been raised by several folks. I'm concerned about capping the upper limit. I just think that sets a focal point, which is a dangerous thing in incentives. You want to be able to get those who continue to perform better. There should be a higher issue. The reward shouldn't cap out, I would think.
I think part of the issue of bringing the negative into play is that hospitals already have the financial incentive under their global budget to reduce readmissions, but then the question is, and not to say that this is going on, but is it easier to sit by and just sit on your revenue base, or to go out and invest and put in all the programs to put in the readmissions? And so while you have the incentive, it does require an investment and initiative. So this kind of puts a penalty structure if you don't get off the bum and get out and make the investment. But some of the reward it's paying itself once you start reducing the readmission. So there is some top limit that we would want to put on, and not have reward on top of reward to some extent, very extensive degree, because it is a self-rewarding system once it gets going. It has to, the investment has to continually be there, but there is a return at a point in that, and so I think that's.
And I agree with that, by the way. I think there has to be a maximum. I'm just saying the maximum shouldn't be where the target is. Wherever the target is shouldn't equate to the maximum reward.
So you're saying maybe if you wanted to cap it at 1%, maybe the target is 0.5%, not 1%, and you keep going up above that to some other number.
And I think, Donna, in line with what David's saying, is if you had this, like we had suggested, portionate, accelerated incentives, you could start from a spot and then maybe go up to the 1%, or even 1.5 to 2%, and then have proportionate rewards that wouldn't be budget neutral, but hospitals would have the incentive then to make the investment. And I agree with everything you said. You got the GBR, which is giving the real incentive to the hospital, but by having this that's not revenue neutral, and in your example, if one hospital or 2 hospitals did really well, you want to give them more. So I think there's an opportunity, and I know you're going to redo this schedule, and maybe there's an opportunity to play there, but clearly for somebody that does over 10%, you want to give them a little bit more.
So am I hearing correctly? Let's assume it's the 10%. then the reward will start with 0.5%, and then we'll scale it up to some amount to 15, or depending on is that what you are suggesting?
I'm not sure that I've suggested a scale at all. I need to understand what the cumulative target is going to be, and that would give me some sense as to the range of the scale, because if we took 0.5% or even 1% at the top end, and we've got to scale 46 hospitals, the incremental difference between each hospital may be so small it's hard to me, understand or agree with the very small differences in readmissions that are being, rates that are being reduced versus the incremental revenue impacts on individual hospitals. And here is where I'd suggest one other thing. And if I'm jumping ahead, please say so, but when I'm looking at the bottom of the page and talking about exemptions, I mean, my concern is particularly for those hospitals who did a better job of also reducing admissions, the denominator, better than someone else, and that's the reason why their rate did not go down as much as someone else, and they then get penalized. And so unless we're going to do something that addresses the admissions issue, and either factor that into the scale or provide an exemption, I don't know how you do this in a relatively fair and equitable way. And one other piece, and again, if I'm jumping ahead, we can come back to it, but I'm going back to the payment model where we have already determined on this payment model that we're reversing the prior year's shared savings and then doing a new shared savings, which I thought was for the readmissions program. Are we going to be replacing that with the net impact of this scale, or are you suggesting we're doing both, and why, if we're doing both?
You're talking about the readmission shared savings program?
Yeah.
So that is different than this one. This one was the readmission reduction incentive program is based on the improvement rates, right? So it doesn't take into account what the actual readmission rates in the base period, right? We're just looking at the % improvement between two periods. The shared savings is a cut on top of it based on the risk-adjusted readmission rates, and it is a % cut for everybody.
Why?
At the same way.
Why? Why doesn't that all get baked into one program?
Because we can't rank the readmissions right now on a reliable way and judge whether one hospital has a higher or lower readmission rate than the benchmark.
Right, but if the end result is to reward or penalize hospitals for their performance on reducing readmissions, it's still unclear to me why you have to have both programs. You develop a target, you develop a scale, and you just have one amount. What you're doing by having the two different programs is making it very difficult, certainly much more complex for hospitals to understand which one they're managing to.
If they manage on the
what the
readmission rate, they're going
what
to
the
be
interaction is between the two programs. Do I end up with a poorer position on the scale for the readmission shared savings program if I do something different on where I end up in reducing readmission rates? It's so much easier, it seems to me, if we have just one program, we understand how that program works, and we manage within that one program. I'm not clear on why we have both programs at all.
Maybe I made a bad job explaining the two. So if you have, let's say, you are an average readmission hospital with 12% readmission rate, and you have a 10% reduction, right? So you would know if you reduce your readmissions by 10%, what the reward that you're going to get, 1%. And you can calculate what your actual readmission rate is going to be with that 10% reduction.
Right.
And let's say you reduce it to 11%. On the shared savings, there is a required reduction, and it's around 6%, let's say. You know, so you're going to be losing 6% of your 6 times 11% of your revenue on the shared savings.
Why?
Because it's the shared savings reduction program.
Why?
Based on your readmission.
I'm not understanding what the policy basis is for having both. If you're rewarding or penalizing me on reducing my readmissions or readmission rates on this program here, why do you then need to come up with an additional penalty or reward separate from that, depending on where they are? I mean, it should be irrelevant where they are if everyone is incented to reduce readmissions, whether they start at 10% readmission rate or 20%. Why is that important in a readmission incentive program where their starting position is? I mean, if that's what you're doing with the point with the shared savings program, I'm not clear on what the policy basis is.
I heard Michelle saying that it is important where you are on the readmission one, right? So the reason why they are separate is because right now there is no good way of merging them together, and they both have problems in terms of the actual measurement. So these are tiny, relatively tiny adjustments that are independent from. Ideally, you could do an MHAC type of program where you do attainment and improvement and you get the higher up. Right now, we keep them separately this year because we can't rank the hospitals and give you a higher of attainment and improvement. So we are incentivizing both the improvement with the reduction program, but also giving a lesser of the reductions if you already have a lower readmission rate. And compared to the CMS program, as you know, is just a reduction program. They reduce the top quartile of the readmission rate. So what we are doing is, in our approach, we are trying to incentivize the improvement and provide positive incentive on the rate. So our approach completely different than the CMS approach. If we are simplifying, we didn't want to go towards just penalizing the hospitals based on the readmission rate and provide a positive incentive. That's why we have two programs.
So I think ultimately there's an opportunity to combine them. I don't think that we're ready to combine them this year based on where we are with the factor analysis. And I think we could potentially put them on a list to combine next year, but I don't think that we're ready to combine them.
Well, then going back to the payment model, what's the basis for increasing the amount that you're putting at risk there?
That's going to come on the aggregate one. Maybe we'll hold it until we look at the total or the aggregate amount at risk when you combine them all.
The basis for increasing it is because it needs to have better improvement.
But that's what you're trying to do. Oh, never mind. It just seems that's what you're trying to do with this program as well, with this readmission incentive program. I don't understand what the argument is for going from a 0.4 to the minus points, from the minus 0.4 to the minus 0.6.
It's not increasing the amount. It's a 0.2% constant.
No, you're taking the payment rate down by 0.2% in this model.
Right.
Which we did last year too.
I know, and I'm saying I don't understand what the basis is.
The basis is that we have too many readmissions and we're taking savings out up front. That's the basis. That's the basis that was there in the beginning, and it's still the basis. And then we're taking it out
with this model too.
Well, we're taking that out on the back end. The other one comes out on the front end, and it gets adjusted on the back end.
I don't see a difference between the two.
One's front end, the other one's back end.
One based on attainment, the other one is on improvement. So then I would skip the other table because it's linked with the first one. Once you have a mistake, it will just run through the whole thing. So the third one is the MHAC QBR scaling. This one came about after we approved the QBR adjustment. You may recall in September, Commission voted for the domain weights for the QBR program. And what we are trying to do is to convert the QBR scaling similar to the MHAC one. So I'm looking at the three, scaling for penalties and rewards based on final QBR scores. So, and then you see a final MHAC score. I would do that as QBR. Similar to the QBR one, what we are trying to come up with is an established point system. Currently, the QBR is a ranking. So as you remember from the last, I showed you the scaling there. So we have the worst performer hospital to the best performer hospital. Half of the hospitals receive a penalty in proportion to their score. Half of them get a reward. And then we do a revenue neutrality adjustment after that to make sure the penalties were equal to the rewards. And the last meeting and commission also approved in January that we are no longer going to do a revenue neutrality adjustment on a program basis. That we are going to discuss on an update, in the update discussion. So once you remove the revenue neutrality requirement from the program, you no longer need to do a relative adjustment. So we could do a point system similar to the MHAC, where the QBR score of 0.05 will be equal to a maximum penalty of 2%, or whatever the maximum penalty we get to.
So that should read final QBR.
Yep. Mm-hmm. And in this way, then what is important is where your penalty ends, where your reward starts. And right now, the way we did it is just to use the last year's scores and then did average. So if you had a score less than average based on the last year's point, then you're going to be receiving a penalty. If you are better than the average, then you're going to be receiving a reward. Any questions on this one?
So these are just proposed?
Yep.
All right. So rather than spend time now, I'd just be curious why we're proposing to go from whatever it is now, the 1% now?
Yes.
On QBR up to 2%.
We'll get to it at the aggregate amount at risk. So this is just as modeled. Then, I mean, if you look at the next table at the hospital specific, so here what you have is the ranking from the last year, the QBR final points. And then the next column is the scaling basis. So this is the existing scale that we have. So we start at 2% for the modeling purposes, and then it goes all the way down to 0.405. In a continuous manner. And then we continuously increase the rewards. And as you see, if we didn't do any adjustment based on the way the points are distributed, the maximum reward is 1.5. And maximum we modeled as negative 0.2. Everyone with me so far? Then on the next column, we calculate the revenue associated with these adjustments. And then in the revenue neutral environment, what we will be doing is we would be reducing the rewards, so our net impact is 0. So if you look at the best performing hospital with 1.5% original revenue, which is 1 million, it's reduced to 766. So that was the revenue neutrality adjustment. And if you look at on the top, none of the penalties are changed in the revenue neutral methodology. What we are proposing is that we would do, instead of doing a revenue neutral adjustment, we link the penalties to the points. And here it's the same because, you know, I didn't make an assumption on what the QBR scores are going to be next year. Right? So depending on what the scores are, the rewards and penalties will be fixed, and we'll see what the total amount is. But here what is important is, in addition to the maximum penalty of 2%, we also need to fix the maximum reward, if you will, so that it is predictable. So we do not open the program to, you know, excess positive on the top side. Any questions? And this is this is similar to the MHAC one. MHAC has one additional component to it, but in this case, it's plus and minuses and average and calibrated to the average score.
One quick question. For us to in fact, to determine what excess is, isn't that both a function of who the hospitals are as much as it is anything else?
Right.
So if I had a different mix of, if the one hospital, Johns Hopkins, that's getting, a large award in this model, positive award, if in the next year their performance was much lower, then we might have a different definition of what that excess award is, because we'd have more money potentially to distribute to the positive hospitals.
Right now, with this one, we are saying we are no longer attaching it to the reward, so it's going to be based on the distribution. And at the end, your total amount is going to be known in March when we do the final scaling.
Right,
but you could assume, you could assume 1%, if the 1% is maximum reward, the maximum total you could have is 1% of total inpatient revenue in the state. That will be the maximum that can come from the QBR.
But that's not the way it's going to work in reality.
It's going to be something smaller.
Right. And so what I'm suggesting is that 1%, if those were all small hospitals that had the better results, you could do something much better than 1% and still end up with a very small number here. Right? So that's my concern here, is that we're how do we, if you will, predetermine up front what that, unless you're saying we have to do it always based on the prior year's results, as to what that 1% should be, what that number should be.
I don't think there is, in the MHAC, for example, this year's calculations are showing 9 million total rewards, no penalties. Once we remove the revenue neutrality, there is no way for us to predetermine what that amount is. We could change and create a different scaling where you can have a pot of money you can decide a priori and then distribute it according to the performance. But then the problem then becomes hospitals wouldn't know what the dollar amount is ahead of time, and that's what we were trying to move away from. With the revenue, without the revenue neutral adjustment, you won't know what the amount is. Then the third program is the MHAC program. As I said, it is similar to the QBR as proposed based on points. The only difference there is MHACs are linked with the statewide performance. On Table 5, what you're looking at is the points for the MHAC and the adjustments depending on whether we reach the state target or not. And here, if you don't reach the state target, the maximum penalty starts with 3%. If you achieve or exceed the state target, then it is reduced to 1%. Commission voted to approve 5% annual reduction for the MHAC in the last meeting, which is down from the 8% that we had for calendar year 14. And we have about 27% improvement in 1 year. So the MHAC performance far exceeded I think anyone's anticipation on that account. And yep. So last year, around this time, we looked at the trends, and on average, we were improving by 10% in the past 3 years. Based on that, and since we have a 30% goal for PPC reduction in 5 years, we wanted to have an 8% target to differentiate. So if we didn't reach 8%, the maximum penalty was 4%. And with the improvement that hospitals did, we reached 27% decline. So since now we are almost there to the 30%, we reduced the annual target to 5%. And did we ever figure out the data issue behind that? Nope. So we have 10 audits scheduled. We heard from all the hospitals that they did coding and documentation improvement, as well as some clinical interventions. And I believe MHA is working to collect the information in terms of best practices for us to understand how those achievements happened. At the same time, we picked 10 most successful hospitals and then we picked 5 most reduced PPCs to really look at the clinical coding and audit the records to see what the changes are. But we won't know them until the end of summer. So why did we change the reduction without doing that? Because we already, I mean, even if it is half a percent, you know, let's say half of them is the coding and half of it is clinical improvement, we will be reaching our 30% target sooner than the 5-year period. So we have room to reduce the annual target. I mean, I think we had a discussion too about what the target is and then what a quality improvement strategy should be, and they should be totally 2 separate items. And so it's not hitting that target, it's continually improving from year to year. So I would be curious to see the breakout actually, data, what the reporting issues are versus clinical coding issues. I can check. I think we can make some of our, for sure, the summary results we can make public, our audit results, and we'll present it at the work groups. From hospital to hospital, there are some confidentiality issues with the patient records, but we'll create a summary report. Yeah. 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 Just looking at the data, it's really hard to find. There wasn't any single hospital that kind of came as the outlier, no single PPC. So it seems like an over-the-board, across-the-board improvement in all of them. We looked at the exemption categories. We looked at the number of ICD-9 because there was a concern with the global budgets. Maybe hospitals were not coding all the ICD-9 codes. There wasn't any correlation either. So we are hoping audit will highlight some of the things that we can see on an aggregate level. So, lastly, the differences between the 2 scales is also, if you don't reach the statewide target, there are no rewards in the program. Only if we exceed the state target, then there is a reward starting at 0.7, and there is a new not revenue neutral, impact neutral zone with the no adjustments for hospitals who scored between 0.5 and 0.7. So I'm going to skip the table 6. It's the individual results based on the current scaling. Just in this case, we did model, so we are modeling 5% improvement and 8% improvement, so you can see the differences based on assumptions. So the next table is the maximum penalties and rewards, and this is where actually where the all tables are linked. For the MHAC, we are proposing to have a 3% maximum penalty. This is a reduction from the 4% from last year, recognizing that we need to focus more on the readmissions since we improve on the MHAC. And the readmission reduction program, the maximum penalty is at 2%, and the QBR modeled as 2%. Shared savings, we modeled it as 0.6%. So on the shared savings, we determine a statewide reduction, and then we distribute it, as I said, based on the readmission rate. So the highest reduction for the shared savings is going to be 1.23%. And then I added the PAU estimates from the last year so that we can calculate the aggregate amount at risk for CMS purposes. Down below, you have the potential at risk totals. As you see, we are still working with CMMI to finalize how we are going to do the potential at risk. The discussions are centered around PQIs. Those are the avoidable admissions. CMS doesn't have a measure like that, and they question whether we should include them in our aggregate amount at risk. So that's why you're seeing the 3 different totals. And on the Medicare side, the HACS is at 1%, readmission is 3% reduction, and the VBP is 2%, totaling up to 6% on the potential at risk. And at the bottom, you see the differences between ours and the national one. So in terms of the justifications why these numbers are, as I said, 3%, we reduced it from 4%. Readmission, we think that we need to have more emphasis on readmission rate and more rewards and penalties associated with it. For the QBR, 2%, it is the same number as the national VBP program. We are right now writing our exemption letter for the VBP, and in terms of looking at our performance, our HCAP scores, patient experience, are, as you know, lower than the national. And looking at the improvement rate, actually national numbers improved much more than our numbers. So we really have to emphasize HCAPs, and that's the reason why we would like to keep it at 2% so we can have more incentives on the QBR to reward the hospital.
On that issue, but don't we in our domains use a different weighting for the HCAPs? Mm-hmm. So then why do we need to go up to the 2% for the same reason? If the reason to go up on the amount we put at risk for value-based purchasing or QBR is because of the poor performance on HCAPs, I thought we addressed that by putting more of the score at risk for HCAPs than they do nationally.
It's two ways of addressing it. Yes, you may have more weight, but if you don't have negligible financial reward or penalty, the weight wouldn't have any impact on the results, I would argue. You have to do both.
So did we see any improvement by going from 0.5% to 1%? Or, I mean, there should have been at least some analysis that relates the amount you're putting at risk to how the number moved as you put more money at risk.
So the improvements we saw in the HCAPs are the readmission-related discharge. You kind of see it is spillover from the readmission policies, but the improvements that we saw there are from the readmission, not from the QBR.
And we did see a couple hospitals really improve their QBRs, I believe, at Hopkins, and Hopkins, one of the ones in the data, and Mercy, and making very big improvements.
Oh, but I just want to make sure we have no way of knowing that going from 1% to 2% is going to have any impact on the HCAP scores, based on looking at any past data.
I would say I would give the MHAC as an example when we increase it from, I don't remember, 2% to 4%. Granted, it's a different measurement, different program, but I would think that the reason why we saw 27% improvement was partially because there was a 4% at risk for the worst performing hospital.
Yeah, but I would also suggest it's because it was an understandable program and a manageable program for the clinicians where the previous one wasn't. That's why we made many of the changes we made that.
That's one of the reasons that we're getting away from revenue neutrality, because in the old program with QBR, if it's revenue neutral, you don't necessarily know what's going to happen at the end, whether there will actually be a reduction or an increase. But if you have a system that's tied to a point system and there's definitely going to be a reduction or an increase, then the incentive is clearer in terms of what's going to happen. So hopefully that really gives more incentive to improve, because you know that there is there's a reward at the end, similar to the investments that we're seeing in that the Medicare Advantage plans are making massive investments in getting to the 5-star program improvements, because there's real money at the end and it's not scaled out. And so this is kind of the same, trying to move down that same path of putting real money at the end, and hopefully we see more improvement.
And the right side of the table is the total revenue adjustments. Again, I wouldn't focus on the numbers. They are not correct. But in terms of getting at the predictability of the final results and how much revenue is going to be impacted, what we are thinking is perhaps we would want to have a limit on a hospital specific. So if to protect hospitals from ranking worse in all of them and having 8.7 or 9% reduction in their revenue. It's a huge amount, and you know, there is a possibility one hospital could all the negative adjustments. So what will be the a point where we could feel comfortable to put the hospital at risk on an overall basis, combined MHAC, QBR, and the readmission. So here, what you have in the table for the MHAC, you know, below target and improvement, the maximum net impact. So this is the combination of all, and it's based on my modeling. This is not going to happen. I guarantee that. But you know, looking at the historical scaling, the maximum penalty one hospital would be receiving is almost 5.5% from all three programs. And on the rewards, it's 2%. And then down below, kind of getting an estimate what will be the impact on the total state revenue. It's at 1.5% of inpatient, or close to 1% of total revenue. This is our worst case scenario. On our a more neutral scenario, the maximum penalty is for one hospital going to be 3%. And on the statewide overall, the inpatient revenue is 0.5%, and on a total revenue basis, it's 0.3%. And those are the penalties. You can also look at it on a net impact basis for the discussions for the update factor.
A couple of questions on the left-hand side of this page. First, the amount, when we talk about inpatient amount, the inpatient revenue that we have at risk is all of our inpatient revenue. The national numbers do not put 100% of the Medicare inpatient revenue at risk, correct? I mean, there is a base, so these percentages haven't been adjusted for that difference. The fact that the base percent of inpatient is not 100% of the inpatient Medicare revenue, whereas in our program it is.
CMMI, so this is the CMMI calculation, and when they informed us when they have their contracts, ACOs, whatever calculations they make, they don't adjust the denominator. Whatever savings that they're doing, if it is an all-payer program, then it is the same percent.
That's not the point that I'm trying to make. We're trying to compare two charts here. We're saying the national program has 6% of inpatient revenue at risk.
Right.
What I'm saying is it's not 100% of all of the Medicare inpatient revenue, so technically it's not 6%.
By contract, we have to hit 6% of all payer revenue at risk.
Yeah, and I'm saying what I'm saying is that part of the discussion here needs to be equating what the 6% in Maryland means compared to the 6% nationally. It's not the same number. That's the first thing I think I'm trying to point out here. Second, what I'm not clear is why for 2017 the end result is substantially higher. The cumulative number, for the moment, forget the cumulative number, but just looking at the 1 year, a 2.7% higher amount at risk, when we also know, as I just said, that the inpatient revenue that's being put at risk is greater than what they're doing nationally. So effectively, it's probably even more than 2.77. What's the basis for doing that much more? I mean, the agreement doesn't say we have to put more at risk. It says at least equal to. What's the basis for doing substantially more?
Because our penalties are not realized. There is also another calculation which I didn't do, right?
That's the same thing nationally. Readmissions is not, they're not realizing 2%.
They are. One hospital.
No, the net impact of their number is around a -0.4 on the inpatient basis.
On an overall basis, but they are reducing one hospital's payments at 3%. What they did is they looked at our impact program from last year. We have 3% at risk on potential.
Yeah.
With the results, we had no hospitals receiving any penalty. So what they are telling us is, how are we going to calculate your realized at risk if you have no penalties in your actual program?
You're mixing terms for me right now. It's not the amount of risk, what you're saying, it's the amount being penalized. Those are two different things.
Not penalized, adjusted. So we are doing absolute. Luckily, they didn't say you have to cut it. So in our case, our positive incentive on readmission is going to count. They are going to be looking at two measures. One is potential at risk, the calculation that you see here.
Right.
The other one, if you remember from the draft, is the realized at risk. So they're looking at the actual implementation.
Where in the agreement does it talk about those two? My understanding, it simply talks about the amount at risk. Where does it say both?
The agreement, unfortunately, didn't specify how we are calculating
it. So we're letting them determine how to interpret a contract that has more than one party in that contract?
They are not.
I don't understand that at all.
Well, I think the question that we have is there some measure? We want to make sure that we have calculations that are strong enough, that are producing the value-based results that are there. And so part of the issue of looking at realized risk versus theoretical risk, we could develop programs that were softballs. And so everybody could hit them out of the park. And nobody would actually have a penalty, but we would hold it up as being something that was a penalty program. So I think the issue is making sure that we design programs that we think are really value-based programs that are creating payment differences when value is achieved, and that it's not a softball that everybody can hit out of the park. So I think that's really the focus of making sure that we're doing that.
Well, I would argue that, just use one example, our impact program, where we have 65 potentially preventable complications at risk, if you will, or that that our hospitals have to manage and is very different in terms of its magnitude than only having to focus on 15 or 20 like they have in the national program. So it's not necessarily the percentage of risk, it's also the fact that I've got to invest my resources across several additional departments, several, an extra 30, 40 extra potentially preventable complications, and that's just one example. I would suggest the fact that we're doing our readmissions program on an all-payer basis is very different than what we have nationally at this point. Not all payers have gone to incentive programs for reducing readmissions beyond Medicare. And so I would argue that the magnitude of the things that we have to pay attention to here is already significantly greater beyond just trying to fix what a percentage should be.
Are you suggesting that the other payers should come up with their own programs?
No, what I'm simply suggesting is that nationally the hospitals are focusing on a much smaller number of conditions, on a much smaller amount of revenue, and because not every payer nationally has adopted those programs, ours are much more substantial in their impact because we're doing on an all-payer basis, much more meaningful that way. I'm saying that should be part of our discussion and argument here, not just focusing in on 8.77 versus 6, which is just
as a Medicaid payer in the all-payer waiver, we definitely want to be counted in that discussion.
Well,
so
I'm not arguing that we not make the programs that are all-payer anything different. I'm not arguing that at all. What I'm saying is if we're comparing our program to national for the purposes of meeting a contractual agreement with CMMI, I'm saying it's a very, very different measure. And I'm not sure we're putting all that information on the table in our discussion here. The fact that the inpatient base is different, the fact that it's all payer, the fact that we look at a greater number of complications, I think all of that requires us to invest heavily, many more resources than hospitals nationally are doing, particularly if we're going to be putting more, suggesting anything more revenue at risk than what they're doing nationally, percentage-wise.
But Julie, just so I understand, the reason we're at 8.77 versus 6 is, like Donna was suggesting, we have an MHAC program with, we had 4% at risk, now 3%, and they're challenging the reasonableness of, is it really 3% that you can justify at risk when hospitals aren't really incurring that? Mm-hmm. So we're establishing a higher amount to really offset that argument.
Partially. I think the other one is we really have the reason why we have the aggregate amount at risk is because originally, before the contract, we were writing exemption letters. We had to prove both we have the similar measure and we had the same outcome or better, and we had the same amount of adjustments. Those three conditions had to apply. With the contract, we kind of separated all these three. For the outcomes, we have the targets now, 30% reduction on MHAC. So we took that aside, and then we now no longer are discussing, you have 15 PPCs here, we have 65. How many of them are correlating, which ones you are leaving behind? So they gave us the flexibility in designing our own program. On top, we have the 30%. And then this is the last portion of that, the exemption requirement that our maximum at risk has to be equal or greater than the national program on an all-payer basis. Right, so we are going to be, right. Right, and that's the point Donna was trying to make. Ultimately, if leaving aside the contractual argument, what is our value-based adjustments in the system? How much money we are shifting around based on the outcome? And to me, that's a better and more relevant for the patients, right?
So, yeah, so I think ultimately we should be focused on where do we want our value-based differentials to be. And is it, you know, where are we headed with that? And if you look at the maximum reward, if somebody goes all out and they can get an extra 3%, and if we keep the scales fair, that's real money. You know, so that is, you know, when you look at the potential there is, you're starting to move toward making it real money, like the, you know, like the STARS type of program of saying, if you achieve these targets, you can have a higher level of reimbursement. So we're trying to say, well, how much are we going to put in value-based reimbursement? And so this says a positive of 3%, which that starts to look like a serious differential between those who perform and those who don't, if you can put it in gear. And you know, I think that if we can, that we should focus on getting comfortable with the program of how much we're putting on value and drive that through the approval process with CMS, and not necessarily get sidetracked on whether it's comparable, but whether, yes, we do have to meet standards with CMS, but the question first should be, are we comfortable with the value program that we're creating for the Maryland patients? Is this a fair value program that we're putting forward for Maryland patients? And then we can add on top of that the question of, are we meeting our contract requirements? But first, is this a fair program for Maryland patients that we're putting forward of differentiating on value? And so I think, you know, we're in this process of change, and we're trying to move from the way we were doing it before to having broader value targets, moving away from just the impact and also emphasizing avoidable utilization, potentially avoidable utilization, and the quality-based reimbursement, the customer satisfaction, and you know, moving that down the road. Ultimately, you know, I think some of the things can come together more, but you know, that's the process of that we're trying to move it down the road.
So where does the global budget fit into this? I mean, I'm 100% at risk within that global budget.
Well, so are the Medicare Advantage plans. They're 100% at risk for their global budget, and so
yeah, but they also don't have the dynamic target that we have in our.
They do. They have a dynamic, but it's actually 1 year's in arrear dynamic target. They're driving 1 year in arrear. That would be nice to drive 1 year backwards so that you would know exactly what your target was. But that's basically the Medicare Advantage plan drives 1 year behind the fee-for-service Medicare program in terms of the per capita targets. And so the CMS is, and Burwell is saying we're going to have more of our revenue at risk under value-based programs, and we're going to move off of fee-for-service programs. And so we have a head start on our global budget model, and we also have to make sure that we tie a significant portion of revenue, whatever that significant portion is, to value-based payments so that people don't sit on their global budgets and not produce the value. So we do have to continue to move the value conversation down the road, and making sure that it's a substantial factor in how budgets are adjusted on an ongoing basis. That's the national strategy, and it's been the strategy that Maryland started on, you know, a few years ago with the quality programs, and I think it's, you know, it's the one that we committed to, and I think that we have to continue to commit to.
And Donna, if I'm not understanding this correctly, but don't we have to be mindful of Medicare spending totally, not just in the hospital setting, but in terms of other settings as well, in terms of looking downstream? What I'm thinking about is that to use your mind, I understand about the part about being at risk, but I also understand focusing on the need for targets. And the targets, the impact of readmissions or admissions in general has an impact downstream on Medicare spending in, say, skilled nursing facilities. If patients don't get admitted, they don't necessarily qualify for the 3-day length of stay to qualify them for Medicare reimbursement in skilled nursing facilities downstream too. So would that be a factor that we should keep in mind as to what we're doing with the readmissions and admissions on total Medicare spending in the state overall?
We are actually, we are getting preliminary monitoring, and now we have to start, we've gotten the data to test the monitoring, but we are getting preliminary data, and so far so good in terms of we're not seeing a shift outside of the hospital that is above the national average. Our ratios are very good so far, but we haven't really tested or kicked the tire. We're just starting to get the data in, and we're not seeing something that's different at this point.
But in fact, the admissions and readmissions ought to have an effect of decreasing Medicare in certain settings such as skilled nursing. because they don't have the 3-day length of stay in an inpatient admission to be able to qualify for Medicare reimbursement and skilled nursing on the back end. So you should not only see, monitor for lack of a shift, but also for maybe even a decline in Medicare revenue for the patients going, that may have had a day or two under observation in a hospital and then don't qualify for Medicare and skilled nursing on the back end.
Right, so you're saying that there might actually be a decline in expenditures outside of the hospital in the skilled side as a result of because they might get home health instead of SNF, et cetera.
Yeah, or they might get
and that there are some other. I can see Trish there. And the other issue with the dual eligibles is that whether they end up on Medicaid's budget instead of Medicare's budget. So that's a topic for another day. And I could see you stepping right into that hole, and Tricia, they're ready to comment on it. Yes, that is an issue for Medicaid budgets. That we don't measure that in the Medicare data.
No. So while we may be good on the waiver test and everything, we may be doing a disservice to Medicaid.
All the more reason to get an ACO for the dual eligibles. So I mean, I think that is the question that we would come back to: are these reasonable programs for evaluating purchasing for Maryland?
All right. So the next steps on this, we have another discussion this afternoon with the performance work group. We are going to go more in detail on the readmission one, but I suspect a lot of the same discussion is going to happen in the afternoon as well. And we will have another meeting scheduled, potentially a combined one with payment and performance, to go over these one more time with the final, close to final modeling and recommendations. Am I missing anything on this one? I think that's it. And I'll send you a corrected file as soon as possible. All right, I'm going to switch to the market shift one, which will be quick. Because the commission agenda was full in January meeting, unfortunately we didn't get a chance to get commission's feedback on the draft principles that we drafted based on our discussions here. That's going to happen this month. So we'll have an update on you for the next meeting on the principles. We are still working on the data. There's been some issues with the data, so we couldn't push out the new formula results to the industry, but we are hoping that by the end of this week, I'm hoping to get them out. And we are scheduling a subgroup meeting to focus on the implications of the new formula and also on the outpatient weights. There's been a lot of back and forth in the movement on the way we are calculating our outpatient visit. So we would need help to iron that out before we finalize the market share. And lastly, in the last meeting, we discussed the dollar value of these adjustments, and I put out some options for you to think about, one being using a statewide average cost, the other one doing a hospital-specific cost, and the third maybe a geographic cost. We will be modeling some of those options and looking at the impact, and ultimately come up with a policy to maintain the revenue neutrality of the program. Any questions on any of those topics? All right. Oh, I guess we had 1 hour to discuss that. I'm sorry. I thought that we were done. I can go on and on if you like.
Do we have any questions or comments from the audience? well, I guess we're meeting adjourned. All right. Thank you so much. Thank you.